there's an app called Symptom Tracker, and that is an opportunity for people to sign in, give us information, tell us what their symptoms are. It locates an area within 50 miles of them where they can be tested. It also will start having follow-up questions so that we can check up on those patients and find out how they're doing now after the potential test, whether they were confirmed or not, if they've recovered fully, if they've had lingering issues, or even worst case scenario, maybe they've gotten the virus again. So we're trying to get that going so that we can have some really great follow-up, which will also help the data that we're compiling on a daily basis, but also just know where our citizens are, how they are recovering from this virus. The other thing I wanted to mention is it also has a tab under resources and recommendations for the drive-through clinics. So if anyone's interested in where someone can go get a test, the drive-through clinics are listed there. Most of the county health departments are by appointment only, and that's mostly just to ensure that we keep those individuals separate from our regular county health department visits. Everyone here, I'm sure, understands that process, and working in the hospitals in different locations. So we're working diligently to do those. Please share that information. If anyone has any trouble with any of those facilities, please let us know. We'd love to make sure that we can make that a smooth process for all of the individuals across the state. We also have on our website, under the news tab, there are executive order reports, which are a very vast report dealing with hospital status. There is information not only about particular cases within the state, that it also breaks it down in percentages, but it also gives you a very good look of like PPE. We also have a report there underneath executive order reports, which does the strategic national stockpile and an inventory list for what is available. We keep expanding that every week. I feel like there's something new and exciting there that we're sharing with our community and with our constituency. And so hopefully you can go there and find information related to lab testing, information related to shortages, what the issue might be, so that we can try to address those issues as far as the different labs and their testing. And then there's also the long-term care or nursing home facility information there at the end of that report. And that is by county, but then it also breaks it down to the facility level and how many cases are residents versus staff, and then total numbers there as well. So I feel like we have quite a bit of information, but of course, if there's ever anything that we're missing or not catching, we would love to know so that we can update that and make sure that we're doing the best we can to get the most fluid information to date to everyone. Just so you have kind of a time frame, like I mentioned, the situational updates and those reports are updated every day at 11 o'clock. The executive order reports are later in the afternoon. The governor's executive order required us to have that report to him by 3 o'clock. So we upload those after that, and usually are there by 4 or 5 o'clock in the evening. And I'm trying to make sure I didn't miss anything. Yeah, I think that's the gist of the reports and what's available out there on our website for those to reach out and touch base, find good numbers and statistics and models and all of that information that might be helpful for you all in your daily lives. We did send out some quick information last week, just based off what the governor did. He, of course, extended the state's safer at home policy through May 6th for those that are vulnerable and over the age of 65. He also announced that we will begin allowing selective surgeries to return around April 24th. So we are constantly monitoring that and looking at that process and how that might affect PPE and other things as well. He also introduced a plan to safely transition us back into business. So we're waiting for some final details on all of that before he releases that, but some really good information for our state. We're looking really good as far as the models are showing. We've kind of plateaued and may have actually hit our peak a little bit before, based off what I have been based off what I've seen from our models. And so we're looking good right now. I hope that everybody keeps it, you know, this is a serious situation to make sure we're all doing our best to take care of the citizens around the state. And I think we're doing a great job of that. on the drive-through testing, just so you have a good number if it's helpful, we have more than 75 drive-through sites set up. And the governor also announced last week that there's going to be 54 mobile units that will be deployed across the state to assist some of our more rural areas. We also, of course, as you know, he announced a hospital surge plan, which incorporates the OSU Tulsa campus and the Integris Baptist off Portland. We released some modeling data, and that shows our peaks and those things that we were talking about just a second ago. And then, of course, we've also had some telehealth options for mental health for those that are needing some assistance during this time, as we know this is difficult for a lot of people being locked up and stuck at home a lot of times, or working from home and finding new ways to do life. So we have some of those, and then a disaster distress helpline as well. We touched on the workforce. I know everybody's excited probably to get back to work to some extent, but we also are sharing information a little bit more broadly. So you'll notice some of the data used to only be county data. Now we're doing cities and zip codes. The other thing that happened was we were able to share more pertinent information with first responders. So we've set up processes to alert them when there's a positive case that they're going to be attending to, and working through those processes. I know we've got a couple people from OHCA and some other places, so they can kind of touch on Medicaid and those types of issues. But I think for right now, that touches on basically the COVID update that I had for everybody. There is antibody testing being done. I'm sure you all are aware of that as well. The one thing I will mention on that is that's not actually being done through our county health departments or the health department itself. That's actually being done by a private lab. So if anybody's interested in that, we can definitely try to connect you with that lab, but that's not something that we're physically doing at this time at the State Department of Health. So just wanted to kind of clarify some of that, because I know that's a lingering question and one of the new things going on right now. I guess I'll stop for a second and see if anybody has questions about COVID, and then maybe move on to just a few brief comments about the legislature and the process they're in right now.
So Ashley, we're going to wait for the questions on updates till after the three of you. So you want to go back to Ashley's slide, Denise, and if you want to do a quick update on the legislature.
Sure.
Go ahead.
Okay, we'll do that then.
Transition to trailer.
Okay. So the legislature is still working remotely. They are doing committee meetings online, similar to this one, and are doing nominations and different things that they're trying to take care of right now while they work on the FY21 budget. The Board of Equalization met on Monday. If anyone was not aware of that, they did declare revenue failure, and therefore the basic options are to move forward with the FY20 budget as the legislature already passed and the governor signs, or go back and potentially do further cuts this year to help mitigate cuts over FY21 and 22. At this point, I'm uncertain as to what their plan is, but I have a feeling we may be just moving forward to look at those. The governor did give some pretty good information as far as what they anticipate if no cuts are made for the FY20 budget and it stays as is. Then we have about a 7.5% cut for FY21, and I think it was like an 8.2% or maybe a little bit higher cut for FY 2022. So we're patiently waiting to see what they come up with as far as the budget goes, and policy and things like that should start back up. I'm hearing around the 1st of May. I'm not sure if they'll go back in before that to address any budget issues, but policy and some of the main things that they think need to go ahead and move forward this year will be addressed. They have extended the deadline so that there is no deadline, no third reading deadline this week. It is now the end of session, which is the last Friday of May. And I think that's it for me.
Thanks so much, Ashley. I appreciate that. We are now going to transition to Traylor Raines, who's the Deputy State Medicaid Director. Welcome to you, Traylor. I don't think you have been to one of our meetings, so we're happy to have you join us, and we'll hear some updates from the Oklahoma Healthcare Authority.
Sure, and I appreciate the invitation and happy to be here. A few updates. I'll go ahead and start with the Healthcare Authority's response to the COVID-19 emergency. As we're all aware, the President declared the emergency on March the 13th. On March the 16th, the Healthcare Authority began responding by opening up our various reimbursable services to use via telehealth. We started all of our medical staff, our behavioral health staff, analyzed which ones could safely and effectively be provided by telehealth. We quickly added the appropriate modifiers to the system where necessary so that most sooner care reimbursable services now are provided by telehealth. We had also were helping to convey the guidance that we're getting from our federal partner, CMS, around the provision of those services. As we know, a lot of our providers aren't necessarily familiar or used to providing services by technology. And so we've been able to get a lot of flexibilities from the federal level, especially around the waiving of HIPAA enforcement during the emergency period for certain technology platforms that wouldn't typically be reimbursable or covered for telehealth because they're not HIPAA compliant. For instance, during the emergency period, Zoom, like the platform we're on now, or Skype and FaceTime would all be acceptable platforms to use during the emergency period, and since HIPAA won't be enforced for those. We have Melody Anthony, the Medicaid director, and I have participated in and conducted like 10 or 11 webinars for our provider communities that were specifically targeted towards different provider types. We did that over the course of about a week and a half. We have created a website on our, or a page on our public site. It's OKHCA.org/COVID-19, where we have posted all of our resources there, including recorded sessions of all the webinars conducted. All the questions that we received during those webinars, we responded to in writing and posted those on that website too. And so if you have questions around certain reimbursable services or telehealth or flexibilities that we've been given, I would refer to that website. More than likely, the question you've asked has been answered in that forum. We did, the first week of the emergency declaration, we also applied for what's called an 1135 emergency waiver from the Centers for Medicare and Medicaid Services. That gives our state certain flexibilities that we need in order to adjust quickly and respond to the national emergency. For instance, we've streamlined our provider enrollment process. So if we have a provider that needs additional professionals or paraprofessionals contracted quickly, in order to best respond and serve sooner care clients, we can do that by waiving the application fee, site visit requirements, and fingerprint-based criminal background checks. That being said, if a provider wishes to continue on as a sooner care contractor past the emergency period, they would need to go back through and conduct all those necessary steps. But during the emergency period itself, we're waiving those requirements. We also have flexibility through the 1135 to prop up those, for lack of a better term, field hospitals. So if a currently licensed and contract hospital needs to set up an annex with additional beds, whether it be to specifically care for COVID patients or to care for less acute patients in that setting while COVID patients are in the actual licensed hospital, they can do that without receiving licensure and the typical credentialing process that they have to go through. That's also applicable to our nursing facilities and intermediate care facilities as well. One important thing to note for those of you that serve sooner care clients, there's been several pieces of federal legislation come down that give certain flexibilities and mandates on state Medicaid agencies. The first one was the Families First Coronavirus Response Act, which you may have heard gives state Medicaid agencies a 6.2% FMAP bump. And so we get additional federal funding in the state through our Medicaid program. But one of the conditions to obtain that 6.2% FMAP is that we cannot unenroll anyone from the sooner care program during the emergency period. For purposes of that legislation and that requirement, the emergency period started March, I believe the 18th, and it goes through the end of the month in which the president declares that there's no longer an emergency. So what that means is if someone was coming up for their renewal for sooner care, or let's say they're a data match that we have run in normal course of business and our eligibility system has determined that their income is above income standards, we will not kick them off of the Medicaid program during the emergency period so that all of our sooner care members can continue to have access to the healthcare needs that they have during that time. And then once the emergency period is over, we will evaluate all those cases on an ongoing basis. The only reason we should see someone unenrolled from Sooner Care is if they voluntarily choose to remove, of course, if they're deceased or if they've left the state. Otherwise, if you have clients that you feel have been terminated from the program after March 8, please reach out to our member services division and we'll do our best to get them reinstated retroactively back to the date that they were unenrolled. We've made all the necessary system modifications to ensure that doesn't happen, but as we all know, there's always a chance for error. But it's definitely not our intent during the emergency time. We originally opened up all of our telehealth codes to the end of the month, this month. April has flown by. So today we'll be sending out a new global message saying that we're extending all those telehealth codes to the end of May, so May 31st. And then we'll continue to evaluate that on a monthly basis. Outside of COVID, let's see, we are still pursuing with our Sooner Care 2.0 Medicaid Expansion Plan. We did submit our state plan to CMS on March the 6th. That would expand to the new adult population. That's adults that would not otherwise be eligible for Sooner Care, with incomes up to 133% of the federal poverty level, with the 5% disregard, which is effectively 138% of the FPL. We're still, of course, it's still contingent on funding, and there's still funding talks happening at the legislature around Sooner Care expansion. But as far as we've been told, we're still moving forward with that. All of our necessary state plans have been submitted. In addition to that, we have also submitted our Healthy Adult Opportunity Waiver, which is an 1115 demonstration project that would not go into effect until July 1st of 2021. So you may have heard about the HAO waiver. If you haven't heard it at the local level, the current federal administration has released this opportunity at the end of January. We submitted it yesterday evening, and we're the first state in the nation to submit this type of waiver. What's different from state plan expansion is that it gives us additional flexibility, such as the ability to charge a nominal premium for enrollees. Again, this 1115 demonstration only applies to those adults that are not otherwise eligible for Sooner Care. So if you are a pregnant woman or a child, age blind, disabled, currently covered, this would not apply to them, just the new adult expansion population. If you are below about 46% of FPL, there's no premium above that. It's a tiered system such that the higher your income, the higher the premium, but in no case at this point would be more than $15 for a family per month. We are also, we've had discussions over the last 2 years around our community engagement requirements, or known as work requirements. We are pursuing requiring that in the HAO demonstration. That would, you would need to report 80 hours a month if you are in this population of either work-related activities, volunteering, or complying with Oklahoma Works if you're unemployed, and other certain qualifying categories of participation. With premiums and community engagement requirements, there are accepted populations. For instance, our American Indian, Alaskan Native population, individuals with HIV or AIDS, a substance use disorder, seriously mentally ill, pregnant women, caretakers of children under the age of 6, or of individuals that have additional needs that you would need to take care of. You would be exempted from those premiums as well as community engagement requirements. We do have, like our COVID-19, we have a page on our website that is specifically dedicated to all things Sooner Care 2.0. That is OKHCA.org/SoonerCare2. There we have a list of all of our public hearings. We answered all of the questions in written form on that site, so you can check out the link to those if you have questions. Again, they've probably been answered. We had 4 of those hearings. We had over 640 individuals attend one of those. And then through our various forums, we had over 2,000 comments, questions, and concerns submitted through our mailbox. So like I said, we submitted that application, the complete application, along with the answers to questions, and our overall response to the comments is found on that page. So again, I believe that's us in a nutshell right now. I'm happy to answer questions later on.
Great, thank you, Traylor. I'm gonna now turn it over to Joyce Marshall, the Director of Maternal and Child Health Service. at the Oklahoma State Department of Health, and Jill Nobles-Botkin, the Administrative Program Manager for Perinatal Reproductive Health at the Oklahoma State Department of Health, who are going to give us an update on the State Maternal Health Innovation Program. Thanks, Joyce and Jill.
Thank you, Barbara. And I'm happy to be here to speak with you today in relation to the State Maternal Health Innovation Program and the latest that we have in this regard. Won't be talking specifically in relation to COVID-19, so a little break and then we'll be back to more on COVID-19. But I, as promised, wanted to bring back more information in relation to the innovation grant that we received funding for this year for approximately $2 million a year for 5 years to improve the maternal health outcomes in the state. Some of the planned activities include establishing a maternal health task force as part of the Oklahoma Perinatal Quality Improvement Collaborative and State Maternal Health Innovation Program grant process. Advisory group, implementing prenatal care mobile health clinics for tribal and disparate populations in high need areas, beginning high risk OB telehealth and telemedicine services, providing e-intervention referral services to pregnant women with substance use disorders, supporting the STARS clinical services tailored to pregnant women with substance use disorders, addressing maternal morbidity through home visitation projects, serving high-risk population, and increasing education on patient safety bundles, post-birth warning signs, and implicit bias in healthcare. Also providing support for moms that have experienced maternal morbidity. So that is beginning with Sarah, who we just were introduced to today. Also evaluating evidence-based programs and promising interventions to determine the impact and improvement among Oklahoma moms and babies, working with the Maternal Mortality Review Committee to identify gaps and provide innovative recommendations and solutions, utilizing the National RIA database, for which we have an agreement now with the CDC to begin as early as this spring, and also convening committed partners throughout the state to work on these and other innovative projects throughout the state to improve maternal health outcomes. In relation to the Maternal Health Task Force, we are excited to provide further information as to the next steps, how each of you can be involved in this process. But before I go into this next part, I wanted to make sure, Jill, did you have anything that you wanted to add?
I think you covered it pretty well. I would just add that it's been a slow process to get some of these projects off the ground, as you can imagine with everything else that's going on, but we are excited to finally be actually getting some contracts in place and getting able to start work on this project.
Thank you, Jill. So in relation to the Maternal Health Task Force, of which we are working with the Oklahoma Perinatal Quality Improvement Collaborative to initiate that process, I wanted to first announce that Dr. John Stanley, maternal fetal medicine specialist with the perinatal centers in both Tulsa and Oklahoma City, and Dr. Rodney Edwards, also maternal fetal medicine specialist with OU, the Department of OBGYN, the section chief of maternal fetal medicine, have agreed to be the co-chairs of the Maternal Health Task Force. So they will be leading these efforts for our state. We are also currently contracting with a national strategic planning expert facilitator who's going to lead us through the strategic planning processes, and so we can capture those most important priorities, goals, objectives, and strategies to obtaining improved maternal and infant health outcomes in the state. This plan will provide the roadmap to guide those efforts. And one of the first steps that's going to come in is we're going to be surveying many of you that are in this meeting today that attend the Oklahoma Perinatal Quality Improvement Collaborative events and activities, along with other specialists in the area of maternal health to make sure we get your input in relation to what needs to be included in the plan, those practices for the next 5 years. We will also be working together to put those then into a strategic planning process, into a strategic plan, and present those back to the full group for feedback and finalization of the actual strategic plan and map that will guide us the next 5 years, with this group as our advisory group. We originally planned to do these events in person, in-person meetings with everyone. Because of COVID-19, that has changed, and now these will be virtual events for the near future anyway. Hopefully be able to move to face-to-face events later, but for now they will be virtual events that will be done. So in closing, I just wanted to reference this week's events and how they took me back to 1995 in response to the bombing of the Murrah building, and then also similar responses I'm seeing now with COVID-19. I've witnessed this response also with many of you, and seeing your tireless efforts to improve health outcomes and the quality of life of Oklahoma's moms and babies. And I've seen that response known as the Oklahoma Standard in you, trying to rise to the occasion, do whatever is needed, and assist those who may be in need, not only to survive, but to thrive. And I wanted to take this quick opportunity to thank each of you for all you do, for rising to the occasion, whatever that need may be. And I'm looking forward to working with you further in this next chapter as we work together to improve maternal and infant health outcomes in our state. So stay tuned for more in the next several weeks and months, and we'll get with you in relation to those efforts and how you can be a part of it and make sure we get your input and feedback. Thank you.
Thanks, Joyce. We appreciate that update. And I should have said at the beginning that Sarah's position is funded through this cooperative agreement between HRSA and the Oklahoma State Department of Health. So we thank you for that support. I am going to turn it over to Barbara Koop, who will let the previous speakers know if we have any questions.
We have had a couple of questions chatted into the chat box. Someone wants to know if OSDH has any breakdown on the number of infants that have tested positive or even been tested at all. Could you answer that, please, Ashley, Joyce?
Yes, so we do have it broken down into age groups, and I believe it's 0 to 4. Let me confirm that real quick with my notes. Yeah, 0 to 4, and we've had 26 confirmed cases at this point and 0 deaths. But that is as broken as it gets. The age groups go from 0 to 4, 5 to 17, and then 18 to 35, 36 to 49, and so on and so forth on our charts. And those are updated on a daily basis.
And the other one, Ashley, would be for you. Someone wanted to know if you could please send out the links that you were talking about. So
sure, definitely.
If you can send those to us, we'll send them. We'll send them when we send the video here.
Sounds great.
If anybody had any questions that you would like to ask that you didn't put in the chat box, I'm going to briefly set this so everybody can unmute themselves if they would like to. We'll give it just a moment to allow you to unmute yourself and ask a question. Doesn't really appear like that's happening so far, so.
Sorry to interrupt. There was one question. How many confirmed confirmed COVID patients have we had in Oklahoma City and hospitals?
Could you repeat the end of that question? I missed after Oklahoma City.
Okay, so and which hospitals?
So on part of the links that I will share with you is a breakdown, and you can search and filter by city. While I'm on, I know I have the county breakdowns right now in front of me, so I apologize. I don't have the city breakdown in front of me, but we can look at that on our website, and I can share that information with you. But it breaks it down into city or zip code. And then it also has an option to look at some other updates under the executive reports. There's a section that deals with the hospital specifically, and it deals with a lot of their PPE and all of their entire reports. So anything that they've submitted to the agency through their daily submissions on that survey, then that information would be located there. So I will share those links with you all as soon as this meeting adjourns, and then you can be able to go look for those and filter however you want through all of that data on the looker board.
And as
Do you have,
go ahead.
do you have any information on confirmed pregnant patients?
I don't actually. I think that will probably be a lot of the process that we work through when we're going through some of the recovery and follow-up questions related to the symptom checker, is to ask, those situations. We've not broken it down to pregnant patients, though, as far as our data points and data sets for the website at this point. There may be some information, and if I am able to obtain that, I will share that with my update as well.
We do have one final question that someone chatted in. It says that at UC Davis, they are testing all admissions to labor and delivery. When will that amount of testing be available in Oklahoma?
So it is actually available depending upon the policy of the hospital. I know for a fact Integris Baptist is doing some of that as well, mostly because my sister's having a baby tomorrow, so she had to have her test today. But I do know, based off policy of the hospitals and those locations, they are making some of those decisions on their own with availability of testing.
So this is Dr. Kincheloe. Can you hear me? Hello?
Yes.
Yes, we can hear you.
Yes.
We have a lot of different hospitals represented here. At Baptist, I know we've had no COVID pregnant patients as of date. Just on a rough survey of people in the room, do we know that we've had any pregnant COVID patients in any of the other institutes that are being represented here today?
Dr. Kincheloe, we will be addressing that here in a moment. So I'm going to go ahead and end the questions for this section now so we can move on. And if there are any questions that are not answered in the webinar today, we will address those and send them to you individually if we have your name, if we know who it came from. So we'll be sharing a little bit of that information here right now, and I'm going to let Denise go ahead. Thank you all to the speakers who provided the updates, and I'm going to turn it over to Denise Cole.
Yeah, so thank you, Dr. Kincheloe, because that was a great segue into what we plan to discuss next. For those of you who registered for this meeting this evening and you indicated that you worked in a clinical position, we did ask further questions to try to get some kind of an assessment of the COVID-19 prevalence among OB patients and newborns. And so as of this morning, we had 20 separate hospitals that were responding. We did have at least one or two respond since then, but we were not able to add them to this slide. But as you can see, of our 20 hospitals, 9 reported that they had some OB patients that were either under investigation or had been tested for COVID-19. So I think one of the respondents since then also indicated that they had approximately 5 patients, so we can say 10 out of 21. And then we went to further ask if they had any of their OB patients that tested positive and only 3 of the hospitals responded that they had any positive cases. 1 hospital said they had 2 positive cases, and then 2 hospitals said they each had 1 positive case. We also asked if any of their positive patients were in the ICU, either with a positive or a presumed diagnosis of COVID-19, and there was only 1 patient in 1 hospital that had experienced that so far. We then asked about newborns and how many newborns had been tested. Only 4 hospitals had indicated that they had tested newborns. I believe one of the later entries also said they had tested, so we may say that 5 of the responding hospitals had tested newborns. And the good news is that nobody reported that any of those tests came back as positive. So of the respondents to this survey, we had no positive newborns in the hospital. And our last question had to do with site conduction of simulations specific to the care of COVID-19 positive women. 12 out of the 20 hospitals reported that yes, they did some kind of simulation, and a few went into more specifics regarding that simulation included donning and doffing of PPE. We did have 1 hospital that said that they had actually done a labor and delivery and C-section walkthrough of a COVID-19 patient or a PUI. And just a reminder that we have a COVID-19 resources page on the OPQIC website. It's opqic.org/COVID-19. We've tried to compile a lot of different perinatal resources. It's in a tabular form, so once you're on the website, if you just click on these different tabs, then you can see the different types of resources that we have submitted.
Thanks, Denise. I'm going to now go ahead and move forward with the COVID-19 part of our presentation, and we're very thankful for the presentations for the presenters we have today. I'm going to introduce them all briefly now, and then they will begin their presentations. First, we'll have Chad Smith, who's the Medical Director for OPQIC and the VP for Medical Affairs at Mercy Hospital in Oklahoma City. Luana Halstead, who's the VP of Quality and Clinical Initiatives at the Oklahoma Hospital Association. Stephanie Bryant, who's an Assistant Professor of OBGYN at Maternal Fetal Medicine at OU Medicine. Patricia Williams, who I believe is not going to be able to present today, but if she gets on, she's an Assistant Professor and the NICU Medical Director at OU Medicine. And Clara Song is an Assistant Professor, Director of Education and Neonatologist at OU Medicine. So I'm going to turn it over to Dr. Smith, and he will give us a brief update.
Good evening, everybody. Thanks for joining us on the call. Hopefully everyone can hear me okay.
Yes, we can.
Okay, awesome. Ashley did an amazing job of kind of presenting a lot of the data in terms of where we stand from Oklahoma's response to COVID-19 and the pandemic as a result. I think there's several good sites to look at. The Oklahoma State Department of Health obviously being one of those. I think if you're looking for, if you're like me, the more data and information you can get your hands on, the better. I like the IHME website as well. And so I've taken slides from their website. And what this is a representation of is hospital resource use. So essentially, how many hospital beds are available, how many ICU beds are available, and how many ventilators are available in the state of Oklahoma. And it maps it out in terms of what those thresholds are, and then kind of what our current peak looks like. And I think when you look at all this data combined, as Ashley mentioned, statistically, it would appear that we've actually surpassed our peak. And that peak probably looks like it was around April 15th per IHME's website. I would say internally within the Mercy system at large, both in the Oklahoma communities, but also across Arkansas and Missouri. We're also seeing very similar data to suggest that as well. Next slide, please. This is looking at deaths by day. And again, just another representation of there was an immediate kind of spike in increase or surge, if you will, and essentially what looks to be a peak that's reached and a planing off effect with ongoing time. The next slide. And then this would be a representation of moving forward. You can see the solid yellow line is kind of where we've what we've experienced to date, and then the projections of what IHME is predicting moving forward and what that looks like. And I think it's important to understand, at least for IHME, what they're assuming is that we're going to maintain social distancing and shelter in place and other mitigating actions at least through the month of May for these projections to hold up. Potentially, some projections would have us looking at the middle of June being the time in which it's probably safer to come off of restrictions fully. So it'll be interesting moving forward to see kind of where we land from a social distancing, what type of restrictions are lifted between now and the future. I think what's important to kind of keep in mind with that, again, these projections are based off of that social distancing factor, what we're going to suffer from, whether it's in the near future or the distant future, because there's a lack of herd immunity, we will most likely anticipate or experience a second peak. The nature of how significant that peak's going to be, we hope it'll be less, but again, it's a little bit of a guessing game at this point to know exactly what that's going to look like. But more than likely, we should anticipate a second peak until we kind of start to develop that herd immunity. Next slide. So I think as we kind of talk about where we've been in the state of Oklahoma and where we're going in the state of Oklahoma, but also nationally, I think these are the major factors that I can identify that remain. One is making sure we still have adequate PPE, and that's, do we use, how long do we continue to do extended use of PPE? Do we look at repurposing techniques for that PPE? Because we do know that overall our general supply or ability to gain supply is limited. Along with that, testing capabilities. So PCR tests, that is ramping up quite nicely. And we're having more and more access from a facility by facility perspective and how we can get access to testing. And that's going to be important for later on down the road, in particular as we start to do more elective surgeries, what processes are put in place around testing with PCR. I will say kind of emerging on the scene is serology testing, talking to my lab experts within Mercy, but then also some other resources that I have. One of the things that remains clear is that when we look at IgM and IgA testing, the literature and the data would suggest at this point that testing is not very good. And so really what we're left with that we can somewhat say is reliable is IgG testing. And at that point, it really just helps us from an epidemiologic perspective to know that we've been exposed and we've had it in the past. Now, whether that conveys immunity, no one knows the answer to that. And so those are some of the questions that remain to be answered. As I mentioned before, shelter in place or shelter at home. Do we lift some of those restrictions and maintain shelter in place or shelter at home for just the high risk population beyond May 6th? I think all those questions remain to be answered, but that'll help determine kind of where we go as a community, where we go as a state, and where we go as a nation moving forward through this pandemic and the crisis. And then lastly, elective surgery. Next slide. And so this was sent out by the governor's office, basically stating that effective April 24th, we would start to do more elective or non-emergent urgent types of surgeries. I will say through all of this, from the moment that this became an issue for us, all of the major metro facilities have been working in unison. We all made a collective decision roughly about the same time of when to stop doing elective surgeries. We all tried to stay within the same kind of guidelines and parameters so that there was a community standard of care. We did that very similarly with crisis standards of care, should that ever have become necessary. Again, we wanted to make sure we had a unified front within the medical community, at least within Oklahoma City, but also Tulsa and the community hospitals as well. So in the same vein, we're attempting to do this. So there's conversations ongoing at each of the individual facilities in regards to how do we start to turn on our OR operations and get them back to typical operations. And pretty much across the board, everyone is supportive of doing so, but in a phased-in approach whereby we take into account potentially risk factors and make sure it's not a flip of the switch where it's all of a sudden back on. It just seems to make more sense that it's kind of a turn the water hose valve open a little bit at a time and gradually kind of work our way up. Now there's going to be some differences in how that approach is taken, but the other considerations within making this decision is, do we do testing universally on all these people? Do we test them with just PCR? Do we test them with serology? Some medical societies are coming out and kind of providing recommendation, but really in full transparency, the true answer is no one really knows what the best thing to do at this point is. So we're kind of working through this and kind of determining what the best approach is moving forward. And then I think lastly, if there is testing done and to what extent it's done, then after that, what do we do in terms of PPE? Do we come off of our PPE policy and start to utilize less and less N95 masks, or do we continue to use those because we know that aerosolizing procedures such as intubation do place certain providers at higher risk? And so these are kind of all the things that the state facilities are working through to make sure that moving forward, we continue to provide excellent service, safe service for our patients in the community. And that's the heart and the focus of the decisions response that we've had, while maybe a little bit sluggish. I think once we started to rally our resources and work together, I feel like the community started to make a very good progress together in unison. So I'm really proud of what we've been able to accomplish, in particular within the Oklahoma City community, the CEOs working together, the CMOs of all the hospitals working together. So I'm very proud of that and very pleased, but a lot of work still remains to be done. We don't know, again, exactly where we're going to be in the next couple of months. This seems to be changing quite frequently, but what we do know is we'll continue to move forward and face the challenges as we are presented with them. So that's a quick update. Thank you.
Great, thank you, Dr. Smith. And now I will turn it over to Lawana Halstead. Thanks, Lawana.
Good evening, everyone. I know we're running a little bit tight on time, so I'm going to try to quickly go through some slides. Can you go to my next slide, Denise? Just wanted to say that at the Hospital Association, it's really been an unprecedented time for us because as a non-regulatory, non-governmental agency 3 weeks ago today, which seems like 3 years ago today, but 3 weeks ago today, the two cabinet secretaries, Casey Shrum and Secretary Jerome Lawfridge, came to our office and asked us if we would create the hospital surge plan for the state. So as you can see, the members of the Healthcare Surge Planning Committee, and down in the members is our president, Patty Davis, for hospitals. So it's pretty unprecedented that we were asked to do that. And it was also pretty overwhelming for us. Next slide, please. So these were our objectives, of course, to protect the health and lives of Oklahomans by ensuring that patients go to the closest, most appropriate hospital in the right amount of time, to try to ensure the stability of the health system for all the patients, because You have to remember hospitals are still seeing a high volume of non-COVID patients. Increased hospital capacity and capability to accommodate a surge of critically ill patients and to protect the wellness of our frontline workers. I think I'll just stop right there and say that you do know that of the positives in Oklahoma, 17% are healthcare workers. We want to really keep that in front of us as we make plans as we move forward. Because Dr. Smith had the more updated slides, this was a presentation that we did last week. I'm going to make the point that when we did an assessment of all the hospitals related to their medical surgical beds, their ICU beds, and ventilators, we did identify that across the state, according to the IHME models all along, we do feel like that we would have adequate capacity in our hospitals. So as you can see here that we, this is a combination of medical, surgical, and ICU beds, and that we have available 4,633. This is after we subtracted specialty hospitals, which if you really had to surge, really like New York or New Jersey, you could also use those beds. And then we also took a 30% out for non-COVID patients, and we still ended up with 4,633 available beds. And the projection at that time was 882, and it's gone down, as Dr. Smith's slides indicated. Next slide, please. This is the same thing with specific to ICU beds, though, that on the date that this came out, which was April 13th, the projection was 218 needed beds, and we had 671. Computed the same way, with removing 30% of what we know is the availability, because we know we would have non-COVID patients also. Next slide, please. The same with ventilators. Now we are calling ventilators and regular invasive ventilators, anesthesia machines, and also BiPAP units, but we have a lot of capability for ventilation in the state, and at that time it was 92 needed, and as you saw on Dr. Smith's slide, it was 77. So we feel really good about the capability, and this was a week ago Friday when the governor did his press conference. This is the information that he used to talk to the state about. Next slide. Now this one is a slide that the governor uses on his daily, that they show the governor on the daily briefing. This is the slide from yesterday. And as you can see, the top blue line, we did an assessment with 100% capacity plus a 40% increase if you had to. We got the hospitals to, explain how they were going to do that, discuss, different techniques and abilities to surge to 140% of capacity. But as you can see, the early IHME model with the green triangles had us surging, at a much higher rate, where as you can see that our current hospitalizations are the teal line at the bottom. And so we have just been lucky, very fortunate, that our hospitalizations have essentially stayed flat. They did go up a little bit today, but that was one day. So we're feeling good about our capacity and capability. Next slide. So this was our plan overall. And our plan was that all healthcare facilities would be participating in the COVID plan, because as you know, we do have COVID spread out all across Oklahoma, and all across Oklahoma, we have hospitals that have ICUs and ventilators. So we wanted to keep the patients in their own regions if that was at all possible, unless they just needed a higher level of care than a hospital in the region could deliver. Also, it was discussed, but we've never surged to the point where we've had to do this, where you would cohort like patients such as cancer patients or OB, nursery, pediatrics. So you would cohort them either in one area in a hospital, or even maybe pick just a specific hospital to have that specific specialty. We worked with the health department, and they have a system called TREC that's for trauma. And the trauma, the state is divided in 8 different regions for trauma, and so we thought we'll just go with those regions for also expand it out for COVID, and that through identifying the resources through hospitals reporting every day into EM resource, which is where the data that Ashley talked about comes from for the governor, some of it comes from EM resource, that they would know where there was capability and could route people to those different hospitals. Next slide, please. Just to let you know, here's the 8 preparedness regions that we have. in Oklahoma already, and that's the model that we thought we would work from. Next slide, please. I just left this one in here, this one, the Tulsa one, in the Oklahoma City region, so that you could see how we divided that out, and so that we knew about the capabilities of each of the hospitals in each of the regions, so that we could utilize that if we needed to for distribution of patients. Next slide, please. And this is Oklahoma City, just to let you know how we did that as far as in the plan. So we did that for each of the 8 regions. Next slide, please. Also with the plan, we divided it into 4 different pillars: operations, logistics, clinical care, and resources. Next slide, please. And then each one of those pillars, we had a 4-tiered plan, the 4th tier being recovery. But tier 1 is where you're preparing for that imminent patient surge. And then tier 2 is when you're starting to reach about 60% of your hospital capacity, but you are still climbing. And so we have always stayed between green and yellow. We have not had to surge beyond that. Now, we picked the 60% total hospital capacity to be the trigger point for moving into tier 2, but some hospitals, it's more at 80%. It depends on their capacity and capability. We just chose that from a statewide perspective. And then tier 3 is when you are at least 90% capacity and moving above 100% into 140%, where other resources would have to come into play from the government. So we took each one of the pillars and divided each one by the different tiers, and this is available out on our website. To cut this down, I didn't include all of the different pillars and the different tiers, but we have that available if you would have any interest. Next slide, please. These were just some ideas that we had about internal hospital considerations to increase staffing. So as you know, as Dr. Smith talked about with the eliminating essentially of elective surgeries, the hospitals were retraining staff from those surgical and procedural areas, and also closed physicians' offices to work in the hospital. Hospitals were planning more like team models of care, where you would have a critical nurse specialist that would lead a team of RNs with like 12 patients, or kind of changing your staffing ratios and changing a little bit of the care delivery model. Next slide, please. And these are just some different external possibilities for increasing staff during a surge time, and we haven't had to do that. It's been such a bizarre conundrum because our hospitals are actually really struggling financially right now because of not having a lot of admissions, and the surge has just really not happened like we thought it might, and that is really a good thing, but it's been very harmful for the hospitals. Next slide, please. This was not a slide that we created, but it was a slide that was created by the team, which we were led by an executive officer from the National Guard, and we've been taking orders from the National Guard, and we've had some incredibly significant deadlines, and it's been quite interesting. But this was in the yellow circle. That is where hospitals are essentially functioning normally, I mean, without external help. But then if it gets to that surge point of getting to about 140% of capacity, then the National Guard and other leadership would open up these COVID flex sites, which in Tulsa it was OSU, and then it was just announced this last week that it would be the Integris Portland campus. At this point, it doesn't look like we're going to have to institute those, but anyway, they're available if we need to. And then, of course, if you even were to overflow that, then we would have to have the military help us to set up other alternative care sites that you've seen happening in other states. You can go to the next slide, but that is my last slide really to talk about. So like Dr. Smith was talking about, we do have concerns about the elective surgery, and he's just, we agree with him 100% that the issue really is, where is the hospital as it relates to PPE? You know, we kind of feel like with 17% of our positives being healthcare workers, that as long as we're in what's called a contingency phase, according to CDC, which is reusing, extended use of PPP and reusing and repurposing PPE, we think we need to be really careful about then implementing procedures that require more PPE. So I know that the hospitals are studying that very closely to help them determine about what they can do actually on April 24th. Also, like Dr. Smith said, it's a really critical issue because the governor's order says that the preoperative process does have to involve a COVID test, and not everybody has rapid testing. But you know, even if it's 24 hours, you have to build that into your process, and that's quite a process. So a lot of questions still for all of us, and that's the end of my presentation. And Barb, I'll be glad to answer questions whenever you want to.
Thanks so much, Luana. And I'm going to now turn it over to Dr. Stephanie Bryant, maternal fetal medicine specialist at OU.
Hi, everyone. I hope to give you a overview of a few basics of pregnancy and kind of what we know. And then also go through kind of our experience here so far and kind of what we're doing and how we've been managing these patients. What we know so far about pregnancy and COVID-19 specifically is that things are changing and we're gathering new information almost on a daily basis. But so far, it doesn't seem to be as severe for pregnancy and the pregnant patient as other coronaviruses have been, or even as severe as some of the influenza cases that we've seen. Certainly there are complications and patients getting critically ill, but as far as the complication rate seems to be a little bit less. So far from what we know, there does not seem to be an increased risk of spontaneous miscarriages. However, there does need to be more data on this. We just don't know all the asymptomatic first trimesters that are actually getting exposed. Preterm birth and preterm rupture of membranes do seem to be increased somewhat. This is likely related to the critically ill patient and or iatrogenic trying to deliver someone before they get critically ill and as an aid to maternal resuscitation. So far, we don't think that anomalies are increased or any birth defects are increased. And there is no definitive evidence thus far of any vertical transmission, that being the transmission from mom through the placenta or through the amniotic fluid to the babies. There are some case reports of babies testing positive within hours after delivery and or having certain antibodies that don't necessarily cross the placenta, meaning the baby may have been exposed. Certainly doesn't, there's certainly no definitive evidence of this, although it raises an interesting question. You can advance the slide. So as far as screening goes, who are we screening? Where are we screening? So we're screening everyone essentially. So as soon as they come into our hospital, whether it's the Children's Hospital on their way to our specific clinic in the Perinatal Diagnostic Center or to the adult hospital, they are getting screened by hospital staff via questionnaire and their temperature taken. There are limited access points both for employees and for patients and visitors. There's universal masking of the patients and their visitors. The Children's Hospital is allowing one visitor, and because our labor and delivery and our maternal fetal medicine clinic, both ultrasound and our high-risk OB prenatal care clinic are both located physically in the Children's Hospital, we are also allowing one visitor currently. In the adult hospital, there is no visitors whatsoever. Once the patients arrive to our door in clinic, we are looking at their screening papers. It's getting confirmed. If they do screen positive, say they have a cough, they have fever, something like that, they are getting walked around to the back of our clinic and then being reassessed by one of our nurses and then proceeding with a regular clinic visit or COVID testing if they qualify. On our inpatient side, very similar, they present to the Children's Hospital, they're getting screened in the same way. Confirmation on arrival to the unit, and then they're getting screened again and evaluated in the OB emergency department or L&D COVID rooms, our specific isolation rooms that we designated, depending on kind of their clinical scenario. So again, we're screening everyone as soon as they walk in the door, again, when they reach our units. And then again, the Children's Hospital, 1 visitor. So our clinics and L&D, 1 visitor. And then for the adult hospital, no visitors. All right, you can advance the slide. So where are we doing testing? And essentially for our OE patients, we have done testing in the resident clinic, although I'm not sure recently how many tests have come out of there. We're doing some testing with our OU physicians, the generalist group, and we are doing testing in our prenatal diagnostic center for the maternal fetal medicine. There is also a respiratory clinic that is run by the family medicine service here that is outpatient, that has recently in the past few weeks kind of ramped up and now has the ability to take patients that are not only screened positive when they reach the hospital, but also if they call in to our nurse triage line and we can get them a telehealth visit or a telephone visit, deem that they need to be tested, and then send them to that clinic as kind of a cohorting measure and to preserve our PPE in our clinics and to decrease our exposure, obviously, to other pregnant patients. And that's been, from our perspective, a success so far in the coordination with all of that. Obviously, we're also doing testing in the OB emergency department and on labor and delivery. All right, you can advance the slide. Who and when are we testing? So essentially, if they have symptoms, cough, fever, shortness of breath, even using things like changes in smell or taste, myalgias, other kind of common symptoms. So patients that call into our nurse triage line that say, hey, I've got this and I may have, my baby's not moving very well, or I have some contractions, we may see them in our prenatal care clinics. In the patients who have appointments, they show up for their scheduled appointment who are screened positive, we'll also go ahead and test them in our clinic. The ones that we are sending to our respiratory clinic, particularly for our clinic, for the maternal fetal medicine clinic, are ones who call in or present with symptoms without OB complaints. That's who they're helping us take better care of. We do consider pregnancy a high-risk category for testing. Although the patients are not seemingly getting as sick, there is obviously the presence of mom and baby. And we know that when pregnant women do get this and they do get sick, then there's obviously more resources, more resource intensive for the maternal units and neonatal and everything else. So we do consider them high risk and as far as needing to know if they are symptomatic or if they are COVID positive or not. Inpatient, if they screen positive for COVID symptoms, if they present specifically for COVID symptoms, so if we have a pregnant patient that comes in, I've got a cough, I have myalgias, we are trying to keep those particular complaints out of the emergency room as much as we can, but obviously patients that come from home, come from wherever, complaining of those things, and then those who develop symptoms during their admission for other causes or during their workup for their OB complaints. Advance the slide. So how we are both inpatient and outpatient is essentially the same process now. We are performing a nasopharyngeal swab. We are using our in-house lab with the turnaround time as quick as about 2 hours. And recently, in the past few days, it's really been 2 to 4. They are still batching them, as far as I know, every 6 to 8 hours. But we had one done outpatient last week, that outpatient at the family medicine clinic, and it was returned, the result was in 3 hours. So it's getting done much, much quicker now. All right, you can advance the slide. This is a big topic kind of across the country. We have not implemented universal screening on labor and delivery or for our scheduled cases on labor and delivery yet at OU. We are talking about it and discussing it and kind of trying to figure out the logistics of how it would work for us. What are the potential benefits of doing universal screening? You would use it in an effort to preserve PPE for those only that are COVID positive, to help limit healthcare worker exposure, planning for the newborn care, and then just for epidemiologic information. It would be nice to know kind of our overall incidence of asymptomatic people because we don't know that kind of across the board. why would you not test? What is the hang up? So testing availability and turnaround time, that is getting better everywhere. But again, like we've talked about, not everywhere has the availability and the turnaround time that we do here. Results that don't come back or results that are positive, potentially causing delay in cases. And then we just don't know how good our testing really is with regards to sensitivity and specificity, and with false negative rates, you know, of the testing being up to 30% is what I've seen. You know, are we really doing something good if we're saying the COVID, you know, we're trusting the COVID test as being negative, and then we're not using our PPE like we currently are? You know, are we then potentially exposing people on the back end because we're falsely reassured by a negative test? Other big concerns and kind of where the logistics lie: where and when do we screen? What if a patient refuses? What if they can't come? Do we test our partners like some places are? All of these are kind of logistics. I know that some of the other hospitals that are doing it, they're doing universal screening. They have drive-through clinics set out specifically for this. And so that's something to consider, but these are all reasons, they're all barriers to doing universal screening and things that you have to really have in place before you jump to doing that. Also, we need to consider kind of the incidence in our local population of how many patients that we've seen. As we've seen across kind of the city, at least, the number of pregnant patients are not overwhelming so far, knock on wood. And so, of course, the incidence in New York, which we'll talk about in a second, they have a much higher incidence of asymptomatic positive patients, but they also have a much higher incidence overall of the disease. So it makes sense from a precaution standpoint for them, whereas here our incidence is much, much lower. Okay, you could advance this slide. Like we talked about, several other LNDs are universally testing. I don't know of any data that they have yet, and I think they've both started. The ones that I know of have started in the past week or so I'm not sure we do have data. I know from our societal Facebook pages and social media that many LNDs are trying to move towards this, but many are limited by the testing availability. So because of that, there's limited reported data so far. You can advance the slide. Columbia from New York has published 2 reports of their asymptomatic COVID positive rates. So the first one was published a couple weeks ago. Well, not published yet, but is in pre-publication. They took their patients from March 13th and through March 27th, and 32% of their COVID cases were asymptomatic on presentation. During that time, they moved to universal testing at their campuses. And so they just put out a correspondence in the New England Journal of Medicine last week for March the 22nd through April the 4th, 13.5% of their universally screened patients were asymptomatic but positive. Several of them became symptomatic during their stay. A couple were readmitted postpartum for complications. But the take home is 13.5% of their universally screened patients were asymptomatic positive, and you're looking at a place that has a much higher incidence than we do here. And that was looking at just a couple of their sites. So definitely, I think, again, more to be learned. It's definitely a discussion of kind of the risk benefits and what can be done locally at your institution based on kind of your capabilities for testing and getting those results back and what you are going to do with those results. Okay, so shifting gears, you can switch slides. Switching gears a little bit. So if we have a COVID positive patient or PUI, where do they go? If they need inpatient monitoring, they will go to, there are specified isolation rooms that we have on labor and delivery that they will go to. They can be evaluated in our OB emergency room and then sent home if they don't meet our specified inpatient criteria. Less than 20 weeks, they are generally being sent to the COVID floor or the ICU in the adult tower, but we are maintaining those that don't need ICU care that are further along, generally on labor and delivery. We do have a specified OR on labor and delivery that we would use for COVID positive patients if we needed an OR. Ideally, we're keeping people out of OBED and keeping them in our OB emergency room and putting them in our isolation rooms on labor and delivery. Again, with the patient flow, once we've identified a patient that is, they tested positive in the respiratory clinic for us, unless they meet OB specific, our OB specific admission criteria, which are kind of based on our regular admission criteria, sepsis, and then, you know, the pregnancy physiology, we offer outpatient management with home quarantine, with phone telehealth, close follow-up, and then if we are able to, rescheduling their outpatient appointments, obviously trying with the goal to limit their OB emergency room or ER visits and limit the exposure to our clinic if it can be avoided. Switch slides. So on labor and delivery, if they need to be admitted, we are recommending that N95s are being worn for all aerosolizing procedures. And right now we are wearing N95s, gowns, eye protection, hair covering, gloves for all deliveries, not just the COVID positive or the PUIs. For routine patient care, they should be, the nurses and physicians and should be maintaining contact and droplet precautions, which is a surgical mask with eye protection, hair covering, gloves, and I forgot a gown. I realized I forgot a gown in there, but gown is also included. There's a lot of debate whether, you can advance the slide, debate on whether deliveries are aerosolizing procedures or not. There is evidence that at least viral particles are found in things like blood and urine and feces, which we are exposed to during vaginal deliveries with pushing and forceful exhalation, coughing, exposure to other bodily fluids. And then if you are thinking about emergencies in obstetrics where you have an emergent intubation, that's definitely an aerosolizing procedure. If you're in the operating room, cautery, and suction, things like that are all potentially aerosolizing, which is part of the reason that right now we are wearing N95s for all vaginal deliveries and C-sections. We have limited, we are a teaching hospital and we are limiting the number of people in the vaginal deliveries and in the operating rooms to minimize our use and optimize our use of PPE. But vaginal deliveries, you'll see N95, gown, eyes, hair covering, and then obviously gloves for second and third stage for the delivering physicians, OB nurse and the newborn nurse. For C-sections, again, for the surgeon, scrub tech, the circulating OB/OR nurse, newborn nurse, and then anesthesia also has their own protection. And I'll let Dr. Song and Dr. Williams elaborate on when and where they are donning and using their particular PPE. We are using our N95s covered by a surgical or cloth mask in an attempt to keep them from getting soiled. And like I said, we have limited who is going into the rooms compared to kind of before all of this happened. All right, you can advance the slide. So speaking of PPE, just as an aside, we are universally masking all our patients, visitors, all healthcare workers and hospital staff, whether they're direct patient care or not. We are reusing these masks unless they are visibly soiled or deformed, if they're unable to be breathed through, or if they're used for known COVID positive patient or aerosolizing procedures. Again, N95s for all deliveries, proper storage, and then we are rolling out a process. I think it's already rolled out in the adult hospital. We are rolling it out in children's as well to use UV light to decontaminate and clean the N95s, and that process is being rolled out. Advance the slide. So as far as other labor and delivery type management, I'll go quickly through some of this because it's very, it's the medicine of what we do, and so we can talk more later if we have time for questions. I want Dr. Song to be able to get through her presentation. So in general, early epidural, neuraxial anesthesia, so a spinal or an epidural is recommended early on to avoid the potential for an emergency intubation, which is an aerosolizing procedure. And we're recommending this for all of our patients, not just the COVID positive patients. recommending no maternal O2, so no maternal oxygen for fetal resuscitation measures, and no nitrous oxide. We don't use a lot of nitrous oxide, but we are recommending against that because maternal oxygen administration and nitrous oxide administration are potentially aerosolizing procedures as well. You can advance the slide. Mode of delivery really should be per routine obstetric indications. You would like to avoid emergent cesarean deliveries, and then when you know you're going to need an OR, such as when you're delivering vaginal, when you're delivering twins vaginally, or doing a breech extraction of a baby, if they're at increased hemorrhage risk, operative vaginal delivery, things like that, you want to move to the OR early on and have the team assembled and all of the appropriate PPE on and in place. Some of this is going to be with the caveat of you're going to have to consider the pulmonary status, the ability to push. You may need to use an assisted second stage, so a forceps or a vacuum. Critically ill patients are obviously not really going to be able to participate in that as much, so you may need to do a C-section. I think it's interesting, many of the studies out of China have had almost a 90% cesarean rate. And I think much of that was, is probably iatrogenic, worrying about maternal pulmonary decompensation and or the ability to push and or to aid in decompressing the uterus for maternal resuscitation measures. You can advance the slide. This is again getting into the kind of, the next few slides are getting into the real like nitty gritty of some of the information that we have. I can go through it very quickly. We can come back to it if we have other questions. Antenatal steroids, there's some question about the, do steroids make COVID-19 worse, the course worse? And I think the answer is probably yes, with extended courses and higher doses than we typically use for fetal lung maturity. So as of right now, if we had a COVID positive patient, we would be giving antenatal steroids for our current indications if we thought delivery was imminent and using it very judiciously. Tocolysis, if not critically ill, probably can use per your routine through the steroid window. Magnesium for neuroprotection or for eclampsia prophylaxis. In preeclampsia, probably use it carefully. NSAIDs, I don't think that the data is very good, and so we are currently not planning to restrict this especially for like our postpartum patients. We don't typically use NSAIDs antepartum or while they're still pregnant. And then you can advance the slide, or you did. Someone asked a question about the preeclampsia and HELP association. We know that COVID-19 does cause thrombocytopenia, lymphopenia, and some transaminitis. There's been increasing reports of encephalitis as well, causing headaches. I think the problem with that, I don't know that there's necessarily an association of one causing the other. I think you can obviously have preeclampsia and other obstetric conditions with COVID-19. I think it's prudent that you're treating both and not necessarily saying, oh, they don't have preeclampsia because they have COVID. I think it's prudent to treat the routine obstetric conditions as well as provide supportive care for COVID-19 if they are positive. Same thing with isolated fever, other infections. Pregnant patients, OB patients will still get things like intra-amniotic infections and postpartum, metritis and that type of thing. We still need to be treating their likely OB complication as well as treating them for COVID-19. The treatment of COVID in pregnant patients, I'm not going to get into detail. Consult with ID. There's going to be different algorithms and different train of thoughts kind of with different at different institutions, and kind of based on that. Use of hydroxychloroquine, azithromycin, other antivirals. The good news is most of these are safe to use in pregnancy, meaning the benefit to mom generally outweighs any risk to baby, or generally outweighs the risk. Postpartum, we're keeping them in the same L&D room for all their postpartum care. Now, Dr. Song probably will get into this. Newborn separation for COVID positive mom PUIs is currently recommended. A patient may refuse. If they do refuse, the bassinet's at least 6 feet away in the room, hopefully with some type of physical barrier, with a well caregiver present. You can advance the slide. With breastfeeding, pumping and bottle feeding may be preferred. Direct breastfeeding with appropriate hygiene and mask is allowable, especially if mom is rooming in. The CDC language is purposefully vague on this. I would caution with early discharges for these patients and or regular patients. They still have common postpartum complications. So I would hesitate to just institute early discharges across the board, and then ideally you'll have a well caregiver at home as well. Can advance the slide. Postpartum tubal is done on a case-by-case basis. I will say generally they're being delayed except for with super high-risk maternal conditions. They are being done with concomitant C-sections, and then this is increased LARC use, which is long-acting reversible contraception, such as IUDs, and things like Nexplanon, so implantable progesterone, or progesterone shots, in order to delay their postpartum tubal until we reinstate elective procedures. You advance the slide. This is a pretty good website that is kept very up to date with some of the good pregnancy resources, COVID. So, and with that very fast, that's what I got.
Thank you so much, Dr. Bryant. Appreciate that. And I will now turn it over to Dr. Song, and hopefully they can stay on, Dr. Song and Dr. Bryant, a little bit later to answer questions, because it looks like we're probably going to run over time. So I will turn it over to Dr. Song. Thank you very much.
Okay, thanks for having me. I'm on my own because Dr. Williams is stuck with actual patients right now. So just a quick review so that we're all on the same page right now with COVID-19. The way of spread, as we know, is airborne, droplets, and respiratory droplets specifically, and direct contact. You know, the evidence shows that airborne can stay in the air for up to 3 hours, and the respiratory droplets can travel up to 2 meters and then stay on contact on contact surfaces for a large number of hours, days, and sometimes for weeks. Next slide, please. So the vertical transmission, as we've already heard, is not a lot of data saying that it's any evidence that it's there. The Chinese studies show that there's really no hardcore evidence, which is fantastic. We've got a lot of positive nasopharyngeal swabs, oropharyngeal swabs, sputum swabs in moms, and then nothing panning out in the amniotic fluid, in the cord blood, and then finally in the neonates. So this is all very reassuring, except there isn't really any definitive evidence, especially with the new case reports that are coming out. The next slide, please. So what's happening now is, as we've already heard, is that there's some new case reports and some new evidence showing that with the babies, we have some elevated IgE and even IgM. And then even more and more studies within our new registries that we have showing that the babies are having some positive nasopharyngeal swabs and some molecular assays coming out, even sometimes with the first negative test, but the second test or even the third test is coming out positive. So there may be some, controversy or some new, concerns that there could possibly be in utero transmission, even though there isn't anything definitive. Everything's coming out so fast, and it's real-time information for us. So next slide, please. What's really fantastic, though, is that we don't have any evidence that the virus is transmitted via the breast milk. You know, the breast milk, we're all breast milk supporters. We want our babies to feed by breastfeeding. You know, there's fantastic bonding, there's fantastic nutritional benefits. So, and there isn't any guidance to say, even for donor breast milk, that we should be avoiding anything. And this deliverance with the donor breast milk. What's concerning though is that, as we know, it's, like I said, airborne, it's respiratory droplets, and specifically with direct contact. So it's that direct contact with the breastfeeding that there's a possibility of perinatal transfer, or that postnatal immediately after birth that we could be transferring. So if there is the decision between our families, between our moms and our babies, to do breastfeeding, then the recommendation is for a mom, even if we're asymptomatic or very mildly symptomatic, for the continued use of the mask. We're all doing it, even if we don't have any symptoms, and meticulous hand and breast hygiene. The other thing though, even if we're not doing direct breastfeeding, is that it's important to know that there could be a risk of transmission through all of the non-porous contact with the bottles and the breast pump. So to be really extra meticulous with wiping down the breast pump and all of the components. So using the disinfectant wipes, and then really hot soapy water, everything that could possibly get in contact with our babies. Next slide, please. So there have been reported, as we said, this the first study out here we've already heard about, the Columbia study, because they've got so many cases out there. Even if our moms are asymptomatic, they've been coming out testing positive. They haven't had any babies that have come test positive. We've had a lot of case reports. I have the great honor and privilege of sitting on the AAP committee. I'm one of 14 who sit on the section on the neonatal perinatal medicine committee. We get together at least 1 to 3 times a week to talk about, you know, what's going on across the nation and what's going on across other units right now. There are case reports of, as I said, babies who are in contact with mom, separated immediately, or somewhere in between. And what's really reassuring is that the babies overall are not symptomatic or completely asymptomatic. There are a few case reports, however, that say that there are significant symptoms ranging anywhere from a little bit of temp instability, mild respiratory symptoms, feeding instability, and you know, sometimes if we have preterm labor and prematurity, it's really hard to discern between RDS or respiratory distress because of prematurity, or it in fact is because of the COVID-19. And then we've all seen the media reports as well. Just last week, there was a case report that came out of a 35-weeker born to a very severely ill mother who actually didn't make it out beyond 1 day of life. The APGARs were very poor, and he ended up dying less than 24 hours. So these kind of things kind of, you know, don't really jive with, you know, there's a huge variability in the presentation of disease. Next slide. So, you know, any delivery or any resuscitation, or anytime we go to, or, you know, expect a baby, we want to be prepared. So we just have to add that extra layer of preparedness for us. You know, there's, you know, the prenatal issues, preparing for any delivery. We never know what to expect when we go. And then preparing that extra level of how do we safely discharge these babies? Who do we discharge the babies to? Next slide. At the end of March, we all got together with the Committee of Infectious Disease, the Committee of Fetus and Newborn, and the section of neonatal perinatal medicine under the guise of the AAP, and came up with the initial guidance. with the intent to at real time update these guidelines on how to manage infants that were born to mothers with suspected or confirmed COVID-19. Next slide, please. So this document and a list of frequently asked questions can be found on this website. This is the official website of the section on neonatal perinatal medicine. So along with this website, if you look onto the last or the middle of the page here, you can also see that we have instituted a national registry for surveillance of epidemiology of perinatal COVID-19 infections. We call it the National Perinatal COVID-19 Registry, the NPC-19. And so we are following any babies that are born to positive mothers that end up positive themselves. Once we have 25 mother infant dyads, we'll be updating our registry and releasing that information on this website. On the third column here, we have the Perinatal COVID-19 collaboration site. AAP members have access to the site immediately, but I think that it's very important for everybody to have all this information. It's a curation essentially of neonatal and perinatal specific COVID-19 information. It has media, resources, institutional guidelines, anything that is specific to, you know, PPE, what other institutions are doing, videos, anything that I can get my hands on essentially, and I put on this site. So if you'd like access to the site, you just have to click the second button there, and you'll be able to get access in 24 to 48 hours. Next slide. So all of these resources that are on here will be available on the Perinatal COVID-19 collaboration site. But these are just a few of what we've curated to review based on what everybody is doing across the country. If I could just bring you over to the left of our screen, the California Perinatal Quality Care Collaborative, the CPQCC, and the Perinatal COVID-19 are two other curation sites. And I noticed that our site, our state collaborative here, you guys have done a phenomenal job at going in and picking some really great examples of things that people are already doing. And so a lot of that came from these other things. But we don't have to reinvent the wheel. You know, people are doing all these things. I think what's really important is that people have acted fast and then are just updating in real time. And that's what we're also doing. So we don't want to make things, you know, redundant or hard. So this is all here for everyone to learn from each other and to keep updating in real time. Next slide. Just so that, you know, just to kind of emphasize that I think that we're a bit lucky that we're trying to react fast and that our babies are not as ill as, you know, some of our adult counterparts. But this is one of my friend and colleague who works at Boston Children's. They're from the IMHE, their peak was on April 15th or April 18th. And she sent out a message to our neonatal community on Twitter and said that essentially a third of their census in their NICU, she said at level 4, pretty big NICU there, was filled with neonatal COVID rule-outs, PUIs essentially. All healthy, and some of their babies were actually positive on testing. Next slide. And so what's interesting is that, you know, the community got together, and this is an example of a kind of an outlier in Massachusetts. On to the right of the slide, some of the moms are actually fairly sick. The babies are not as sick. The cases at the time of this screenshot, there was only 3. She's since then updated to say that there's a handful of positive cases. And among those handful of cases that she's seen, a portion of them were immediately separated immediately after birth, no contact from the moms. A portion of them actually stayed in contact, and a portion of them had direct, in the room, and a portion of them had direct breastfeeding with the moms. Well, what I call option A, option B, option C. Next slide. So that all brings to question, is there, our big question about the vertical transmission. What I've been involved in pretty closely with our institutions here is, how should we be doing this at OU? We acted pretty fast, and we needed a plan. So our delivery coordination plan for how to manage our babies is we got together a few times a week and figured out how to, work with the nursing staff, our RTs, our nurse practitioners. We have a number of fellows. We have a lot of people who cover not only the delivery room, but a huge number of neonatologists who are on call during the day, on the weekends. And we figured out how to do the donning and the doffing process. The studies show that if you do it correctly, the donning and doffing can take up to 6 to 7 minutes. And it's the doffing process that is really the key point. Some elegant studies out of Harvard actually show that in the adult, if with the aerosol generating procedures, that they can, splay, so, the virus can splay so much that it can, land in all sorts of areas that are not covered by the PPE. So this is pretty, just a pretty sophisticated process that people need to practice. At our level 4, it's pretty routine for us to go to a lot of delivery. So it's not the NRP that needs to be practiced, but all those other logistics. So if you look at the middle picture here, what we've got on our preterm mannequin is a viral filter. This viral filter is one that we use on our ventilators. It is not the correct size. It's a neonatal viral filter. The neonatal viral filters are on back order across the nation. So we made some concessions. We ran some simulations on how to, modify the pressures and modify our hold in order to ensure that the dead space was correct for this kind of mannequin. And these are all the things that needed to be practiced and simulated. So I always say 90% prep and 10% performance. Next slide, please. The other things that we did, because in these kind of situations is what we call a halo, a high acuity, low occurrence procedure or event. We created a visual guide for our huge, faculty and multidisciplinary group, and we also have a video here. It's not searchable, but if you have the link, you can follow the link, and it goes through if we have a COVID positive or a suspected infant in the NICU and requires an intubation. And just to review, any CPAP, PPV, NIV, or intubation, or even deep suctioning process is an aerosol generating process. The CDC, the AAP now are incongruent and are aligned with the definition that a PUI mother will designate the baby as a PUI. So all of those babies will be designated as PUIs until the mom is negative, and so those babies should be treated as such. Next slide, please. So this just takes some close collaboration with our OB and MFM colleagues. I just actually had a COVID positive mother come in today, and she had tested positive as early as the 6th of this month and continued to test positive when she came in today. And so what was very helpful was that our colleagues gave us some lead time so that we could be prepared for her delivery. You know, the earlier we have notification, the earlier we can prep everything. The minute she walked in the door, we had some time. The minute that, you know, we were called for the delivery. What's really helpful is to have, you know, whether it's a low risk delivery or a high risk delivery, that we're on standby. The recurring theme here is that, you know, we want to, you know, limit the team members and limit the unnecessary use of PPE. So that kind of lead time is really helpful. Next slide, please. So specifically, our approach at OU is this pared down and simplified one pager here. So this is what we have around the hospital, and we share this with any of our partners down in OB. We actually have this to show to our families. And when our babies are born, I think what's helpful to discuss with the families is when our mothers feel okay, they're asymptomatic or very mildly symptomatic, and our babies actually come out and are asymptomatic and have the ability to otherwise stay with families, go through the options. So in that, the green box is at the bottom, when the baby's asymptomatic and does not require an ICU. The AAP, again, and the CDC recommend separation until we have tested negative times 2 tests. So the 2 tests would be at 24 hours and at 48 hours. So 2 tests, 48 hours apart. The AAP goes one step further and to say an additional test at about 14 days. Now that's not a hard and fast rule. That's just with the caveat on what your institution is able to do. Not every institution is able to, you know, have that kind of testing capability. I think what's really important though is to have what's called, you know, that shared decision-making model with the family, because, you know, the temporary isolation and separation from baby is the safest for this kind of situation, but not always the right situation, right decision for each family. So, you know, there's an option B and C. It just kind of stratifies the risk and possibility of exposure and of disease. And at this point, with the evidence that we have, we're not quite sure, you know, what kind of exact risk there is. And with the benefit of the breastfeeding and the breast milk, you know, there's a balance. So there's also that option of staying with the mom and using express breast milk, but, you know, 6 feet away, and or using a curtain with the 6 feet away. That's that middle green box. And also, you know, just direct breastfeeding with the caveat of good hygiene and cleaning, and asking mom to use a mask. So that's that lower right-hand box. Next. We also love, you know, working with a team. So we made these, you know, recommendations closely with Peds ID. You know, at a minimum, the AAP recommends doing molecular assays. So a PCR, again, at 24 to 48 hours, at least 2, a nasopharyngeal swab and a throat swab would be best, but one or the other will be good enough. There's also some studies that show that the virus has a reservoir in the stool. So if a stool sample could be taken, that would be even better. At St. Anthony's NICU, we do all 3 tests at 24 and 48 hours. If there's any reason or any inability not to, if you can't do those tests, then the backup plan for that would be close monitoring for 14 days after discharge. We've also collaborated with pediatric anesthesia. They have a COVID airway intubation team here. We ourselves are the NICU intubation airway team for our own patients, but they have a very fantastic intubation protocol that we've modeled our intubation after. So those kind of collaborations are really helpful. And also outpatient pediatric and follow-up, as I said. So the ongoing issues, just jumping down to the very end, there have been on a national scale some issues with early discharge and readmission of a lot of these newborns. The AAP, we've actually written a letter to the pediatricians in the state of New York because there have been an issue there with babies going home at 12, 24, and 36 hours and then bouncing back pretty early. So that creates an issue of, do all the babies need to be tested when they come back in? And do these babies have increased risk of COVID-19 infections because of the early discharge, and then compounded by, whatever other issues. And then we have actually seen some readmissions because of hyperbilirubinemia, just the normal newborn issues. That's it in a nutshell.
Thank you so much, Dr. Song. We are at our time limit, but I hope that we can get some questions here in a minute. Denise, if you'll go back, Dr. Song and Dr. Bryant mentioned the registries. Those are listed on our website, so on our COVID-19 page. So I want to make sure you're aware of those. And then hopefully the doctors can stay on for a little bit for questions. And if there are any questions that are not answered during the meeting tonight, we will address them individually. Just so you also know, we are recording this and it will be on our website along with the slides. So I'm going to now turn it over to Barbara Koop to summarize questions within the chat.
Okay, our first question is, it would be really useful to have pregnancy specific information in terms of Oklahoma. A lot of us are working with data coming out of New York, which is not necessarily the same as the picture here. So does OU as an academic center or the state health department plan on tracking pregnancy specific data? I would assume that would go to either Dr. Bryant or Joyce.
I can answer for OU. We haven't had any yet. We've had one outpatient. Dr. Song, was that patient here today positive? OU, or was it at one of the other hospitals?
No, it was at our level 2.
Okay. So yes, I think we are keeping track of, at least in our clinic, of the outpatients that we've had that have tested, all of them tested negative so far. So that is could definitely be something that we do if we end up seeing any.
So is that published anywhere for other hospitals to look at?
If we had the data, then we would eventually attempt to publish it, yeah. But right now, we don't have any, so.
Okay, the next question is asking about a breakdown by ethnicity of positive cases in Oklahoma. And Actually, if you go to the State Health Department site, which is coronavirus.health.ok.gov, that is in there.
Yes.
That information is in there.
Yes, it is listed on that site. And it specifies each race and each ethnicity and the percentage amounts.
Thank you. We have a question of who is performing the test at OU? Who is actually gathering the test? Is it nursing or the lab?
Our nurses collect the specimens and send it to the lab, and they're processing it.
Okay. And I know you were talking about that you limiting the number of people in the delivery room as far as healthcare workers. The question is, how many learners do you allow in the deliveries at this time?
Is one resident in vaginal delivery and one resident in the C-sections, with the attending obviously scrubbing into the C-sections and then being right there and available for the vaginal delivery as well if needed.
We have a question from one of our physicians that asked if you were really saying that if there is a fetal pattern that requires intrauterine resuscitation, are you not giving the mom oxygen?
We are not. Regardless of COVID, maternal oxygen hasn't proven to help change any fetal outcomes. We're not using oxygen for these COVID positive moms for fetal resuscitation purposes.
And then we had two other questions. One was about the relationship between preeclampsia and COVID-19. Is there any relationship there?
I don't think we know that. I thought I answered that in my presentation, but I don't think we know that. I think we know that COVID can increase your LFTs and cause some thrombocytopenia. Sick can be hyperdynamic as if they're not septic, so that can cause some elevated blood pressure. I think that it's probably most likely is that you have preeclampsia and COVID-19. If someone is getting sick with COVID-19, could it potentially mimic preeclampsia? Yes, but I don't think we know that there's an actual association yet.
And one final chat question. Are infants born during this time period that are C19 positive, are those being monitored in the future? Are we doing any way of tracking them into the future?
So on our AAP perinatal COVID-19 registry, they will be followed. So we currently have 51 hospitals and institutions registered, and there are 43 that are enrolled. So we should be able to know. Our institution, OU, is currently in the enrollment stage. So we may not know the mothers who are positive, but we'll be able to track the infant mother dyads that are enrolled.
Okay, that is all of our chat questions. I'm now going to allow the participants to unmute themselves and ask any verbal questions that they may have or statements.
So I guess my question is that the CDC has updated their guidance on the care of inpatients to clarify that they did not actually recommend routine separation of even COVID positive moms. So I know the AAP, I've seen and read the AAP statement that came out, which their own section on breastfeeding actually did not approve. So it seems like we're not in alignment with what some of the recommendations are out there. And with the data that's been presented, we know the data about the impact on breastfeeding when we separate mothers and babies and when we aren't doing skin to skin, and increase in hypoglycemia and hyperbilirubinemia, and yet we're not seeing these babies, if they stay with their mothers who are having any, really serious adverse outcomes. But we certainly know the impact that we can have on breastfeeding or lack of breastfeeding when we wait. So any thoughts to updating?
Yes, so the AAP met with the CDC just this past week about that, and Mark Hudak is our section chair. He spoke actually directly and had a New York Times interview just on this, and there is a divergence, I guess, with the WHO as well, because the WHO and the Chinese the studies, as Dr. Bryan I think was presenting, because the abundance of their practice is to, again, the C-sections and an immediate separation afterward. So we don't have a lot of that great evidence to go by, because they did immediately separate all of their infants and their mother dyads right afterward. So it does have that impression and look that there isn't vertical transmission. But those case reports that we're seeing afterward now is that it's kind of muddying the waters right now. Our AAP statement is specifically addressing our national community, not not the global community. And what we're so worried about is the direct contact. And I really appreciate, and I can understand the skin to skin. And I think that is the point of contention, because the skin to skin contact is so important, especially immediately after delivery. And I think that the opinion and the concern of our pediatric infectious disease experts is that the direct contact in the skin to skin is what is putting the babies at risk, because of the perinatal and the immediate postnatal cases that they have seen, because there isn't any other explanation that they have at this point. So it isn't the breast milk or the breastfeeding. It's that direct contact.
Right, and yet what is the actual risk when, at least what we know of cases, if babies have tested positive, that they're not really getting sick? I know there have been 2 infant deaths reported in the United States, and I even just checked today that still neither one of those, either in the 7-week-old or the 11-month-old, one was in Connecticut and one was in Chicago, and both medical examiners in those states have still not confirmed that COVID was actually the cause of death. They think there were other causes. So
yeah, so that's
that extreme either, but
that's what we're not quite sure of yet. We do have some cases. I think there is a study of there's a presumption of COVID pneumonia with negative tests, and we do know also that Dr. Bryant showed the sensitivity of the test in adults, which we don't know in neonates right now, is roughly about 71%. So there is a pretty false negative rate. She quoted 30%, which is about what we all know, because the sensitivity is like 71%. So we have no idea what the sensitivity is in our babies. We think it's pretty good, but it actually is not the greatest test, but that's the only one we have. So that was on that last slide, is that, that's the ongoing question right now, is what is the best test? We don't know what the best test is, actually. So we don't have a great way of monitoring, the actual disease process. So it's clinically. What is fantastic is that the majority of our babies, we do believe it's very benign. But we do have these, outlier cases that are pretty extreme. And we have had a handful of, unstable cases and cases that have pretty significant pneumonias that fortunately get better and resolve.
Well, and then do you know, were those all in newborns during the birth hospitalization, or were some of those in older babies? And do we know if those babies were breastfed or not?
The 10 cases that I'm talking about, those were all in neonates.
And do we know how they were fed? Do we know if they were breastfed or not?
Those were in cases in China, and so they were immediately separated.
Yeah, they weren't allowing any breastfeeding.
Yeah. So that's why, yeah, so we don't have a whole lot of great information. And so without that information, without all that like hard evidence, and that's one of the reasons why the most conservative and the safest recommendations have come from these groups, from our groups.
Dr. Song, I'm Dr. Melinda Webb. I'm a pediatrician in Stillwater and the OKAAP chapter breastfeeding coordinator. We're currently in contact too with some of the physicians, the neonatologists and pediatricians in New York City, and their experience has been pretty good. That again, they're testing, they still room in, and they still do direct contact. And as to date, they've had only one infant test positive. So I'm going to try to send that to you via your email so that you have that, that you can take back to the AAP as well.
So yeah, this is actually not a universal mandate. As we said, we have all these options. We're trying to do what we call, the shared, decision-making process with the families. This isn't something that I think is easy for any of us. And I think that it's most paramount to have a conversation with the families. The decision that we had with our family today was that they would practice with the mask and do direct breastfeeding in the room. I think it's most important though that everybody just has all the information with them. This is the recommendation. We have everything out there. As long as everybody knows both sides of where we're coming from, then it's really just working together with the families. Not that it's a complete dogma one way or the other.
No, I totally agree. I think the other part that we sometimes forget as well as that we just need to have that conversation too about safe formula preparation, whether they're breastfeeding or bottle feeding, that caregiver needs to be healthy, that the caregiver, if they're bottle feeding, also needs to have good hand washing and also should wear a mask because like you said, it is direct contact. And I think sometimes we focus so much on the breastfeeding and that contact that we forget that bottle feeding, if families choose to do that, may also be a risk. So we would definitely support breastfeeding, but there is still a risk with bottle feeding, and they need to weigh that out as well. That needs to be done in a safe manner, both with preparation of the formula, preparation of the bottles, and then who delivers that. Because we know also that if the mom is positive, the dad or another caregiver that's in contact with her may also be a PUI.
Oh, absolutely. Yeah. So that goes every way, whether it's a bottle for the formula or a bottle for the express breast milk or for the donor milk. It's whatever is exposed that's a non-porous surface, essentially. Everything has to do with just good hygiene and cleaning, cleaning of the surface. That's the bottom line. So in this kind of situation, just with any kind of situation with the newborn, it's about communication and making sure that, the decision is made before, and that, whatever it is, it's a decision made together, that it's what the families want. We're just trying to convey, what's the safest thing for the baby, and that we have a backup plan. So.
Totally agree. Totally agree. Thank you.
Mm-hmm.
If I can, I would like to just clarify one other, because we've been getting a lot of questions at the Oklahoma Breastfeeding Resource Center and through the Milk Banking Association as well, about just handling expressed milk, if it's a COVID positive mother, whether she's in the home and sending milk, to the NICU, or is, separated in the hospital and trying to provide milk for her baby. We have to be really careful when we talk about trying to clean the containers of milk, and anything that we're using as far as someone at healthcare staff transporting milk to the NICU or to the baby's, the well baby's isolation room, that it's food safe, food grade safe, that we're not using some kind of chemical or disinfectant wipes that can actually potentially contaminate the milk with something that would be unsafe for the baby as well. So we've seen a lot of kind of hurriedly put together policies and things that are recommending all kinds of wipes that are actually not FDA approved to be used in food contact kind of situations. So, and the Milk Banking Association has some recent guidance on that that's on the website. So.
Yes, we've added that to our website as well. So that should be available for folks if they're interested in that. So in the interest of time, I'm going to move on to our final slides. And if you do have other questions, you may submit those via email and we will try to get those answered. A few updates before we end the meeting. We are going to be sending a COVID-19 survey to hospitals and to ask a little more detail about some of the issues that we've addressed today during the webinar. So be on the lookout for that. We do have our annual summit scheduled for October 2nd, 2020. We don't know if we'll be able to do that in person. If not, we will have some type of virtual event that day. So please go ahead and continue to save that date. And then our future meeting dates for OPQIC, such as we did this evening, we have one coming up on October 20th and January 19th. And as we get questions from people, we do know that there are perhaps some other opportunities for webinars, and that's one of the questions on the survey. So we will be providing those as we need to. For our final slide, we just want to thank you for being with us tonight. And we're all about quality improvement, and certainly the COVID-19, all of this planning has been an exercise in quality improvement and continues to be one. So whatever, we are learning lots of good lessons that I think we will be able to apply in many different ways. We have here ways that you can reach us. If you have questions, please follow us on social media. And again, we want to thank you all for your work that's being done in whatever way you are out there in Oklahoma. And we certainly appreciate everything that you're doing. And we will hope that you have a good evening, and we will talk with you soon. So thank you, everyone.